We have 2 cases as most months and December, and basically December is Mayo month. We have 2 presentations, the one this morning by Dr. Jake Sellon, but also in 2 weeks from now, we'll have a carpal tunnel presentation by Dr. Jay Smith. So again, just a reminder, in 2 weeks, we'll have our last one of the year, and it'll be a carpal tunnel case. But this morning we have Jake Sellon, very fortunate. Jake comes to us, as I mentioned, from the Mayo Clinic, where he is inbred. He did his residency and fellowship at Mayo, and then joined the faculty. He currently is the fellowship director, is involved with a number of research projects, and I can just tell you from a personal standpoint, Jake and I have shared patients. We've shared teaching at conferences, and I would describe Jake as soft-spoken, but incredibly thoughtful and incredibly talented. So we're very fortunate this morning to have Jake Sellon present a medial ankle case. And I'll just turn it over to you, Jake.
Okay, well, thanks so much, Doug, for that kind introduction. I was really happy when Doug assigned me medial ankle. I think I've scanned that less than all the other body regions. But just kidding. No, it was actually really good to dig into this, and it'll give me a chance to unveil my tarsal tunnel release device. So we'll go ahead and start off. I want to just thank Doug and Ryan and Maderick for putting this series together. It's really kind of, I think, exceeded all expectations. There have been some amazing presentations. I went back and watched a few more that I had missed, and it's just it's a really nice archive for people going forward. So thanks again, guys. And obviously, I want to thank my mentors here at Mayo, Dr. Smith, Dr. Finoff, all the residents and fellows that kind of keep me in line over the years. So now you guys are out there doing your thing, so it's great to see. So we're going to be talking about kind of the same, same topics within the medial ankle. We'll talk about, review some of the relevant anatomy and sonopathology, and then at the end we'll go through a diagnostic ultrasound report of a medial ankle scan. This is I just wanted to highlight this paper. I know Julia brought this up too the other week. If you guys haven't looked at this, it's just a nice reference. It goes through all the major joints and either by evidence or consensus, talks about what are the indications for diagnostic ultrasound at each joint. And you can see there's really not, for ankle, there's really not too many things that ultrasound is not very good for. So in this grading scale, a grade 3 is the first choice, and grade 2 is equivalent to other imaging. So I think over the years, there'll be fewer and fewer zeros and ones. Basically, if you need to have a comprehensive view of a joint, obviously MRI is probably better. So the case we're going to talk about, this is a 48-year-old female nurse who had an atraumatic onset of medial ankle pain 7 months prior. This was posteromedial ankle and heel pain, worse with weight bearing with the first step out of bed. And she described plantar arch and forefoot paresthesias going to her first toes. And she really noticed this at night when her ankle, inside of her ankle, would rub against the other ankle, and was really disrupting her sleep. She had been treated for presumed plantar fasciitis, and had tried very comprehensive treatment program short of doing anything invasive, and had not had any improvement over 7 months. So she was referred for an ultrasound consultation with a question of medial ankle and heel pain and possible tarsal tunnel syndrome. So before I get started, I wanted to just talk about our approach to the ultrasound consultation. I think everybody probably does this a little bit differently, but I think it's worthwhile, especially for the fellows and people that are just getting out into practice, to think about this. It really probably depends what sort of practice setting you're going to be in, how you might do this. But you have to think about when someone refers you a patient, it's not always the same. Sometimes it's a very simple thing where you're just really asked to be a radiologist and give the diagnosis. But, you know, more often than not, you know, you're a clinician, you have skills that are different from a radiologist. And so, you know, you can potentially be a very helpful and sometimes may, you know, take on care of the patient. And so you need to just kind of think through how you're going to handle those things and what effect that might have on your schedule, on billing, all those kinds of, has a lot of implications. And so, like many of the other speakers talked about, I definitely want to emphasize the importance of making sure that you're familiar with the history and exam before you go into the ultrasound scan. And this is, you know, you could obviously review the notes if it's coming from a trusted colleague, or you can perform this yourself and, you know, potentially do a separate clinical consultation. Definitely need to review prior testing. Radiographs, as others have said, are very complementary to ultrasound, and you know, not just imaging, things like EMG. Encourage people to make sure you take advantage of all those hints as to what may be going on. Obviously, you need to make a decision about complete versus limited, just with regards to billing. And then, as I mentioned, you know, is the physician basically trying to pass the patient off to you? Do they want your expertise just for a specific question, or you know, or is the patient better off with you taking care of them? So those are the things that you need to consider, and obviously that's going to have implications on your documentation and billing. So with this case, our nurse, we're going to start with the radiographs, and there's really not much exciting going on here. She's got a fairly large calcaneal enthesophyte and pes planus, but nothing really going on around the medial ankle otherwise that that would make us suspicious. Obviously, we're kind of wondering about plantar fasciitis just based on her history of having pain with first steps out of bed, and she's got this enthesophyte as well, so definitely on the differential. So then what do we do next? We see the patient, we're getting ready for the ultrasound. And I think, you know, even if I'm not going to do a full-blown physical exam, as other speakers have mentioned, you really, if you do a careful palpatory exam, that can be so helpful, especially in body region like the foot, where things are, you know, very superficial. I mean, you can really, if you're careful with your palpation, you can limit, you can narrow things down very easily. Now, it's not always that easy. Sometimes patients have more diffuse symptoms, like this particular case, but in a lot of cases it is. So then you select your transducer, typically high frequency transducer in the ankle. Small footprint can be helpful with the bony prominences, lots of gel. And then from a positioning standpoint, I usually have the ankle externally rotated and resting on a towel here, so I can have a bit of range of motion that I can use into external rotation or eversion. So my medial ankle protocol is as follows, and I think with medial ankle, I feel like more than some other areas, I sometimes tend to expand a bit beyond kind of what a lot of people look at as the standard protocol. So I've bolded the items that I would just about always do, but I just included some other things that, depending on what may be going on, I might take a look at. I think there's a lot of overlap with the plantar heel, potentially, and sometimes posterior heel, sometimes intermediate, or sometimes anterior ankle as well. So I think most people are familiar with the tendon anatomy around the ankle. I will just say I'm not going to go through the plantar exam, but in this patient, just given her history, we did take a look at her plantar fascia, and she, of course, had this large enthesophyte like we knew from the radiographs. The plantar fascia was just slightly thick. This is plantar fascia central cord at about 5 millimeters, but you can see as we go to the short axis view, you can see this hypoechoic region that's consistent with a high grade, at least a partial thickness tear through this area. This would be medial, so it's kind of through the central area of the fascia. with some cortical irregularity underneath. So you're thinking this is probably a deep side partial tear that's extended near the surface. So we know that going in, okay, she's got plantar fasciitis, but doesn't really explain some of the other symptoms. A lot of the medial ankle pain, obviously the paresthesias. So we go through some of our standard protocol here with the posterior tibialis. And I think probably most of you guys are familiar with the Tom, Dick, and Very Nervous Harry anatomy here. So we've got an axial view of the tarsal tunnel with the posterior tibialis tendon. This is something that you may or may not do, and I don't always do, but something you should think about is flexor retinacular injuries. And so you can do a resisted inversion technique, and you want to make sure that you're not pressing down on the area. So you would use a little gel standoff, and we're just watching the posterior tib as it activates bulge against the flexor retinaculum. And so this would be a normal, our case, a normal situation. This is just an example. Like a lot of other people, I stole a case from Jay Smith here. This is was a teenage athlete that had an eversion ankle injury that Jay saw years ago, and he's doing the same maneuver here, and you can see how the posterior tib partially subluxates, and you can see this sort of delamination of the flexor retinaculum. So, you know, not a ton of literature on this, but it can potentially be a pretty devastating injury because a lot of times I don't think it's recognized early. In this particular case, the patient was immobilized and actually did well with non-operative treatment. So back to our case, we're going to take a look at the posterior tibialis and short axis going distally down to the navicular and then beyond to medial cuneiform. You can kind of see the pathway that we're following there. This is, as we get down to the insertion, we go back into long axis on the posterior tib, and our patient had a osticle here that looks like a type 1 accessory navicular, which is a sesamoid. It does a little bit irregular in its borders, so, you know, I suppose an avulsion fragment could be another possibility, but she really didn't have any tenderness at the site. Could have been an old injury, I guess, but I think it was probably an accessory navicular. Interestingly, she had some Doppler flow there, but no tenderness at all, no pain with resisted inversion. So I didn't think this was at least a major contributor to her pain. Now, this is just a different example of a more normal looking posterior tibialis insertion coming in from proximal to distal with the navicular tuberosity. And then you can see, obviously, the posterior tib has a very broad insertion over navicular, medial cuneiform, base of multiple metatarsals as well. And you can just see how that continues on. This is just not our patient, but another example of what tenosynovitis would look like in this area. So this is a posterior tib as well as FDL tenosynovitis with fluid and hyperemia. Okay, so moving on to our Flexor Digitorum Longus exam on the patient. This is just a short axis sweep, and we go from the tarsal tunnel down. So following the tendon. There we go, tendon here, medial plantar nerve here, and you see it crossing over right there over the FHL at the master knot of Henry. Looks pretty good there. And that's just another close-up view. This is an area where people can get jogger's foot. So, you know, she does have medial plantar paresthesia, so I always make sure to do a careful sonographic Tinel's test over all these nerves to see if we can reproduce symptoms, and I wasn't able to reproduce her symptoms at this spot. you can look at this area in long axis, usually not something that I would do routinely unless there was something of interest at the knot of Henry. So then moving on to FHL. So we're starting at the tarsal tunnel, and again, a short axis sweep here with anterior to the left. And so it's going by the medial tubercle of the talus. Let's see. There we go. Medial tubercle, and then I think I misspoke earlier. There we, and then it's at the sustentaculum tali there. So those can be a little bit, if you're just starting off, can be a little easy to confuse at the talus and the calcaneus. Again, looks pretty good in that area. So at this point, we've looked at the tendons. She's got some hyperemia at the posterior tib insertion with an ossicle in the area. It really doesn't seem to be symptomatic at that spot. So moving on to the nerve exam. So this, we're obviously suspicious here, and just a review of anatomy. I know Ryan gave a great talk going through these nerves, so I won't go in great detail, but it does kind of highlight how there is some overlap a lot of times between the medial ankle and the plantar heel. And so this is just a view of the tibial nerve. I usually would start up in the supramalleolar region to look for any early branch offs of the medial calcaneal or other branches. Then we come down to the retromalleolar space. So we have tibial nerve. So this is going to be posterior tib FDL with FDL muscle, posterior tib vessels, and then our FHL is anisotropic here. This is a video of showing the medial calcaneal branch coming off. So we see the split and this little guy here coming out. You know that it's got to be the medial calcaneal because it's going into the subcutaneous space, and it has a little vessel next to it as well. Again, patient did not have any sonographic tennels or tenderness directly over the medial plant or the medial calcaneal nerve. With these tiny nerves, sometimes, you know, there may not be an enlargement that you can pick out, and so you really have to rely on palpation a lot of times. Medial plantar nerve, so, you know, this is kind of matches up with her symptomatic distribution, and we already took a look at that down at the knot of Henry. Didn't really see anything previously, so medial plantar nerve looks good. The lateral plantar nerve, coming off here. So lateral plantar is going to take a head more in a coronal plane and pass through this interval between the Abductor Hallucis and Quadratus plantae initially, and then going on between FDB and Quadratus plantae as it comes around into the heel. So it looks good here. We often think about Baxter's nerve because that's the first branch off of the lateral plantar, and it's a known cause of heel pain. Usually innervates the abductor digiti minimi muscle, and so this can be a difficult nerve to scan because it's so small and it makes this tight turn around the heel. This is, one thing I like to do looking at this. So this is where it's already come down out of the tarsal tunnel, and we see the Abductor Hallucis and the Quadratus plantae interval. And so you've got the lateral plantar nerve, the Baxter's branch that's already come off, and I like to use the vessels here because they'll often split these two nerves, and if you look for something hyperechoic and kind of sweep back and forth, a lot of times it'll be more conspicuous, just like in this little cine. So lateral plantar, Baxter's branch, and just kind of little movements back and forth. A lot of times your eye will pick up on it. So with any concern for tibial neuropathy, we're going to be looking at the muscles in the foot, at least a screen. So Abductor Hallucis obviously is on the medial side. So get a look at that, as well as Flexor Digitorum brevis and Quadratus plantae. I don't have a picture of ADM here, but it's very easy just to move a little bit further lateral and take a look at that. It's not on the medial side, but again, classically with Baxter's neuropathy, you'd think about that affecting the ADM. So when we take a closer look at the tarsal, or at the tibial nerve passing through the tarsal tunnel, we did actually notice something abnormal with the Flexor Hallucis longus. So right here, you'll notice this anechoic region. So right here, we've got the FHL tendon right here. This is going to be right here. This is the lateral plantar nerve, or tibial right there. And you see this anechoic area that seems to be adjacent to the Flexor Hallucis. This was relatively non-compressible. So, a lot of times if you have a tenosynovial effusion, you can compress those fairly easily. And this was not compressible, and it seemed to be relatively loculated at this one site. So no internal Doppler flow. So it seemed consistent with a ganglion cyst. And obviously a ganglion cyst inside the tarsal tunnel could potentially compress the structures, and certainly could be and is likely causing her tarsal tunnel symptoms. So this is just a still image of that cyst. A couple other things that you might see. This is a different case. There's an accessory muscle, Flexor Digitorum Accessorius Longus, that is another just kind of space occupying structure in the tarsal tunnel occasionally. And this is an MRI correlate of cross section of the muscle. So you see the FHL tendon, FHL muscle, and then this is this extra FDL here. And so we've got a little cine of the ultrasound version. If you see this, if you see a muscle layer, normally the tendon of FHL should be more superficial than the muscle. So if you see this prominent muscle at the superficial surface of the posterior tarsal tunnel, that should raise some red flags for FDL. You can certainly get schwannomas, obviously, anywhere in the body. This was just another case of right here, huge big schwannoma from the medial plantar nerve. Just goes from looking relatively normal to just obviously abnormal. Don't forget about the posterior tibial vessels. We don't often do a lot of vascular ultrasound, at least most of us don't, but you can obviously get thrombus, and you can have different anatomic variants. This was just kind of an unusual, this was a tarsal tunnel eval that I did where the artery actually passed through the tibial nerve, and then the nerve came back together. And so it's kind of an unusual situation. Wasn't really clear that was what was causing the symptoms, but obviously there can be some anatomic variations here. So just always make sure you take a look at the vessels as well. All right, so shifting gears into ligaments. I'm going to talk about the spring ligament. It's definitely something that should always be part of your exam. The spring ligament is the supramedial calcaneal navicular ligament. So connects the calcaneus and the navicular there. And this is a long axis view in that same orientation with the sustentaculum tali of the calcaneus and the navicular tuberosity. And this basically supports the talus. This is the head of the talus. And then anisotropically, you got the posterior tib over, running obliquely over. And you can put this on tension by dorsiflexing, everting, externally rotating the foot. So it sometimes makes it easier to see. This is our patient. You can see the ossicle here, within the posterior tib that we saw before, and then her spring ligament. And we're just doing a little bit of a stress test, basically. It looks pretty good. Deltoid ligament. So, this I think can be a little bit intimidating at first if, you think you want to try to identify all the different components of it. I'm not sure that that's absolutely necessary, but really it's not that difficult. They're all just named by the bones that they connect. There are two layers, the superficial and the deep layer. I usually just kind of run from posterior to anterior. The deep posterior tibiotalar is by far the most important, the thickest component of it. There's a superficial component of that as well. The tibiocalcaneal is also in the superficial layer. Tibiospring just connects from malleolus to spring ligament. And then you've got the tibionavicular, and then on the deep side, the anterior tibiotalar. So just running through those real quick. I wouldn't necessarily go through every single one of these on all medial ankle exams, but obviously if there was an eversion injury, suspicion for deltoid ligament injury, I would. So here we've got the superficial and the deep posterior tibiotalar. You can see how thick that posterior tibiotalar ligament is. And the way to find that is just to follow posterior tib down until it crosses over that ligament. Tibiocalcaneal, we're just going to sweep or pivot a little bit anteriorly, and we can see connecting from malleolus down to the calcaneus at the subtalar tali. And so we can see both the tibiotalar joint as well as the subtalar joint as well. So that's a good time to stop and take a look at those. Tibiocalcaneal is just showing moving from the deep posterior tibiotalar onto tibiocalcaneal. So just a slight pivot anteriorly. Then moving on, as we're moving anteriorly, tibiospring. So now we're connecting the malleolus directly to the spring ligament, which you're actually seeing here in a short axis. May not be used to looking at it like that, but it's a useful view of the spring ligament. Pretty easy to get this image. It's pretty much straight coronal. And then you've got, again, the posterior tib running over the top here. And this is just a cine of that sweep running from tibiocalcaneal anteriorly to tibiospring. And then finally, our most anterior portion, we've got a superficial layer running from malleolus all the way over the talar head to the navicular. That's the tibionavicular. And then on the deep side, this patient happened to have a little effusion here. It helped us define the anterior tibiotalar deeper portion. Again, you can do a little bit of a stress test by plantar flexing and everting. I didn't have any great cases of deltoid ligament injuries, but I have seen this a few times where someone will have chronic pain and I see a ton of vascularity within the ligament, and I don't really know what this is. I've gotten an MRI on some of these folks. This is often like without any trauma history, or at least that they remember. So be interested if anyone has seen things like this before. This is the deep posterior tibiotalar ligament. You can see just totally lit up, person with chronic medial ankle pain. Subtalar joint, just mention real quickly here. It's fairly complex anatomy if you haven't looked at it in a while, and I just want to emphasize that there are really two separate portions of the joint. And so when we think about injecting the subtalar joint, typically we're talking about the posterior subtalar joint, and it's separated by this capsule. The anterior portion of the subtalar joint is really kind of an extension of the sinus tarsi here, and you can see these two facets. So the subtalar tali is sort of the dividing point between the two, but this is really where we tend to think about symptomatic arthritis, and where most of the time we'll do our injections in the subtalar joint. And this is just a view. Someone's got this person has a very tiny effusion here, but and you can obviously try to stress the joint if you're worried about some instability with an eversion sort of talar tilt type maneuver. You'd want to have the patient dorsiflex to lock the tibiotalar joint doing that. And then finally, just ending with kind of a fun case I just saw a couple weeks ago. This is I've seen this multiple times here in Minnesota, but hockey player comes in with this big ball in their ankle. I had never heard of this until I was here with all these hockey players in Minnesota, but this guy had, had this aspirated, injected multiple times, just a big ball of fluid, subcutaneous fluid. And we ended up treating him with doxycycline sclerodesis. He actually is doing well so far. So hopefully it won't come back. But you want to be careful in this kind of area that, you take kind of a long track in there, because obviously there's an infection risk if you come in directly, or more of a risk. So lastly, just want to go through the report of our patient. And this is, again, how I tend to do it. I tend to use a little bit more prose, I think, than template type verbiage. But I always include a little bit of a history if solely doing a diagnostic ultrasound. If I've decided to do a consult, I will do a separate consult note, and I would just reference the consult note in that section. But otherwise, I like to go back and kind of, be able to, it helps me kind of frame the report if I have a summarization of the history up front. Obviously, location, what we're going to image, indication, comparison studies that we reviewed, type of transducer, and then our findings. So you can see what I've done here is basically prioritized what I think are the most significant findings and kind of broken it down by paragraph. So in this first paragraph, we're talking about that FHL ganglion cyst and why it appears that is causing this patient's tarsal tunnel syndrome. The next paragraph talking about the nerves themselves, how there was some nerve irritability with sonopalpation, but no actual structural abnormalities of the nerves and no signs of muscle atrophy. Then I talk about the plantar fasciitis. Obviously, that seems to be a component of this patient's symptoms as well. Going over both central and lateral cord pathology here. And then I sort of end by talking about the things that I don't think are as relevant, the accessory navicular, vascularity we saw, and then I just mention all the other things that we scanned that were normal. So I usually end my reports with kind of one sentence that sort of lists everything that was normal. And then I've got my impression, followed by the plan, because we were asked to do a diagnostic scan as well as inject. So I think we are out of time here, but basically the summary is that ultrasound is a great tool for medial ankle scanning, and I think it really helps to have a systematic method, but you need to be prepared to go outside of that in some occasions. So that is it.
All right. Well, Jake, that was, I always say the sign of someone who is quite advanced with ultrasound is you make it look easy, and you certainly make some fairly complex anatomy look easy. Those nerves can be very difficult to find in some people, and obviously you took a stepwise approach to that. Just a couple quick comments. I just really want to reiterate a couple things you said, particularly for people getting started. One is, I've also seen a number of cases of a flexor retinaculum small tear at the tibial insertion. It's frequently missed on MR, but well seen by ultrasound. So I think Jake reminds us to include the flexor retinaculum in our medial ankle exam. I think sometimes I tend to forget about that, and that's a good reminder. My second comment is, if you're starting out with this, be comfortable with the sustinaculum tali and its morphology, because it's nice. It's a nice landmark. Things attach onto there, as Jake pointed out. The Flexor Digitorum Longus traverses right over the sustinaculi. So it's a good bony landmark to be familiar with if you're newer at the medial ankle. Another quick comment is that a small amount of fluid without other associated abnormalities in the posterior tibialis, and certainly the FHL, which in 10 to 15% of the time communicates with the talocrural joint, is not unusual. And if it's out without associated other findings, such as flexor tendon thickening, hypervascularity, I will often report that as a physiologic fluid. And then finally, Jake pointed out some of the causes of medial tarsal tunnels. So one of the things I include in my medial protocol is just a straight coronal connecting the tibia or the medial malleolus with the sustenaculi tali. And I see the medial talocalcaneal joint, which about once a year I pick up a unsuspected talocalcaneal coalition, which is a known cause or important cause of medial tarsal tunnel. So that's just a image that I've over time just included in my medial protocol. So again, Jake, you make it look very easy. Any other comments or questions?
Hey, this is Mederic. Great job, Jake. The deltoid ligament hyperemia that you showed, that's something that we'll see not uncommonly in a lot of our high-level athletes as part of this sort of medial ankle, whether it's some medial gutter impingement mixed with some post-tib tendinopathy. But I've been surprised. I get a lot of these sent for what seems kind of like a post-tib issue. And they end up having a lot of that, hyperemia with both within the ligament and then also in, and it looked like your case had that too within the kind of the medial gutter there as well. And so we've been targeting that. Like if we're going to do, a PRP or something on those folks, I've typically been putting some in the post-tib tendon sheath as well as into the deep aspect, in the medial gutter there as well. So it is something I think that does come about, fairly frequently. I also feel really old because that case you showed of Jay's of the unstable tendon is when I was a fellow. So that's that's an oldie but a goodie.
Thanks, Mederic. Yeah, I mean, I've done the same thing with that the deltoid ligament. I've tried to treat a couple with PRP, had some reasonable success, but it's just the pathophysiology is interesting. I hadn't thought about impingement. I mean, that could be what's going on.
All right, so just again, a reminder, in 2 weeks, we're gonna have a carpal tunnel case by Dr. Jay Smith. Just a quick teaser. I know Jay is gonna toggle back and forth between actually showing a cadaveric dissection to correlate with his ultrasound findings. And also a reminder on that session is we're going to be on Microsoft Teams rather than Zoom. And we will send out a link, both to an e-blast as well as a digest about that link. So in 2 weeks, we're going to have a different link, a Microsoft Teams link again, but we'll make sure that everybody has access to that link. And again, Jake, thank you for a really quality presentation.
Well, thanks so much, guys.
Yep. Have a good Friday and weekend, everybody.